All right, Sarah, hit it.
Cool. Just to piggyback that, there's I'm working with the speech and language pathologist, looking at aspiration risk and trying to identify a subset of our population that are particularly high risk, whether that be because of trauma mechanism or existing comorbidities. So you will also see a protocol that's sort of in the works, not a whole lot different from how we do bedside swallows and things like that for patients who are not intubated, but rather to identify this distinct population who's at particularly high risk to ensure that we're following sort of to the letter our typical swallow evaluation and getting speech path involved very early for patients who are high risk. So not as much eyeballing them as really assessing them according to the standards that we already have in place. So you'll see that roll out probably in the next few weeks. And I'm actually going back to look at our existing data just on pneumonia in general, which may reveal some more information about that ventilator associated pneumonia and maybe help us troubleshoot that further. So that's also on the horizon, hopefully. So I'm here just to give you guys a brief overview of some of the things we're doing to try to improve communication with our patients and families. And the bottom line of this is underlying all of it is the concept that all of us as care providers provide some level of primary palliative care. So, and really all that means is that we recognize, acknowledge, support, and document our efforts that are already happening to make patients comfortable, address symptom management, communicate effectively with them, and really target and care for the whole person, including their psychosocial needs, which all of us already do, but the opportunities for documentation, for integration into the chart and things like that have not historically been there. So we're trying to address that. So in updating our trauma protocols, there is a new protocol that we created for geriatrics specifically, though we know that that patient population is not discretely defined by age, and comorbidities play a huge factor. So as we've brought in the geriatrics team, who we will start sort of filtering in, hopefully you'll start seeing them even at maybe in the ICU level, or particularly as they transition to IMU. You'll also see in terms of our communication and documentation of that, a rollout that for patients over 65, this is the criteria from the protocol, over 65 or under 65 but with pre-existing end-stage disease. We are going to try to meet some standards that are established by the American College of Surgeons nationally, that we have timely, meaning very early conversations with our patients and document them. So the first 24 hours, our goal will be to sort of follow two pathways. One, identifying the healthcare proxy. If there is an advanced directive or pulse already in existence, getting that into the chart and scanned and reflective of their code status. And two, early prognostication. So the team is identifying the extent of injuries, doing their tertiaries, getting all that imaging, where we're going to ask that the nursing staff be involved because you guys are at the bedside, you're seeing family, you're seeing patients, and for those who can participate, is trying to assess what the functional status of the patient was prior to admission. There is a growing body of literature, which I'll talk about in just a second, to support this concept of frailty being a major factor in prognosis. And in order for us to accurately provide information to patients and families and help them troubleshoot goals of care while they're in the hospital, this information is really integral if we can obtain it from our patients and their families. So just to highlight, again, there's a lot of literature that's come out over maybe the past 10 years, and particularly in the last 5, regarding frailty as an excellent marker for morbidity and mortality in hospital. This initially was in the medicine literature and has come through to surgery and is particularly pertinent in the trauma literature. There are a myriad of different scoring systems, some of which are more complex than others to try to assess this, but all of them have been found to follow and closely correlate with morbidity and mortality. So this is the one that we, excuse me, are putting into our protocol. It is only 5 questions, but sort of targets concepts of fatigue resistance, ambulatory status, their previous comorbidities and illnesses, and weight loss, all of which suggest frailty. So these are the 5 questions that we're going to ask that as the nurses, particularly in the first 24 hours, that we try to elicit this information from patients and families. And then there's actually going to be a smart phrase in EPIC that allows you to input the score, which we will use to help triage patients in terms of consultations for other support services, look retrospectively and prospectively in research context so that we can identify patients who are at risk to try to optimize the services that they have and the opportunities that they have to limit morbidity and mortality in the hospital. It's still rolling out. There's some little glitches, of course, in EPIC to make this available to everyone. The idea is to try to limit how much work this creates for you and to make it as streamlined and simple as possible. So as you can barely see because it's tiny on the screen, but essentially all those questions are listed in the smart phrase. So if you type in .frail in a new note, this will pop up. It gives you all 5 questions, and then it's a yes, no, yes, no, yes, no. And each question, if there's a yes, you get a point. And you add them up and you put in the score, and that'll be a drop-down menu, hopefully, that we can query in EPIC. And then if the score is 3 or greater, it sort of opens up a line of triggers that we, as the physicians on the care team, need to roll out, consults and things like that. As you guys become more comfortable with it, if you identify patients who are 3 or greater and you want to page the resident, say, hey, by the way, this patient is really quite frail, they have a 3 or 4 or 5, by all means certainly do that, because that will just help facilitate the integration of this information for us. So that you know sort of how this will roll out. Additionally, with these really sick patients, they're, again, nationally a movement to try to have early goals of care conversations. So those patients who are over 65 in the SICU, over 65 with multiple rib fractures, polytrauma, with the high frailty score, or those who have end-stage disease under the age of 65 who are also frail, they will, our goal is to have them have within 72 hours of admission, either they, if they're able to participate, and or their families, a conversation regarding goals of care. So really more concretely establishing a plan moving forward, establishing code status, changing code status if it's really inappropriate, whatever their admission status was, so that we're identifying early patients who we anticipate will do poorly, who aren't expected to have meaningful outcomes, and not prolonging the course of care if that's not appropriate. And the other point of this is also to build trust and comfort and improve communication for families and patients. So this is happening on the backside. The fellows and residents are actually getting formal education in communication and palliative care. And my hope is actually that the fellows will spearhead most of this process. So they're going to be responsible for looking at the chart and making sure we're hitting those 24 and 72-hour marks, and then also communicating with families and patients. And the palliative care team is facilitating that education as well. It's a pretty intensive program over the first month that they're here. And then we're going to follow them and proctor them out through the first 6 months. And then they're going to help to proctor the residents so that they also gain a better understanding of how this works. So this sort of resident run only kind of activity will hopefully dissipate over the next few months as the fellows take over. That's the last slide, but I really, as this stuff is happening, please give me feedback if you feel like things are derailing or that things aren't going well from the fellow or resident perspective in terms of communication, because it's new and it's really important that you guys are on the ground and see most of the things that happen. So you're my eyes and ears in the unit.
hours to do a frailty score, I feel like there's going to be some roadblocks, like if patients are intubated or have neuro injury.
Absolutely.
Most of our, it's mostly why we can't fill out a KGB.
Absolutely. I anticipate that as well. Just as important as actually filling out the frailty score, I don't know if you saw it, sorry, go back to that slide. There is an, sorry, technologically incapable today. Hard to see, but basically there's an opportunity in the, it's not right, in the notation, it's yes, no, or unable to assess. If the patient's intubated and they have no next of kin and whatever, just write unable to assess, because that information is just as important for us to know as getting the actual frailty score, because we are actually being held to these guidelines by a national standard that is evolving, and it's important for us to be able to sort of feed back and say, hey, we're really trying very hard to do this, but these are the hurdles we're encountering. And so if you can't obtain the information, that's fine. Just document unable to assess. And although I don't have one in here, we may be worth putting in a line that just indicates the reason, just to help us follow that population and identify people who we really are having trouble with.
Can we go back in after the 24 hours? Like
yes.
If you got extubated or something?
Yes. This thing is just a dot phrase, so you'll be able to, it's a ready reference that pops up. And it'll go in a note that's labeled goals of care. So it'll end up in that advanced care planning tab. So you can add as many as you like. The more the better actually for our documentation. So that's okay.
And is the pulse something that we can obtain for patients, or is that something that you guys give them? Or?
So patients who come in with any kind of advanced care planning documentation, so that's advanced directives, living wills, a sheet of paper where they clearly wrote what they wanted and signed it, pulsed. In the state of California, nurse practitioners, PAs, and physicians can all fill out pulse with patients. Of import, it has to be signed by one of those care providers and the patient. There's no witness line for it, but those two signatures are integral to have it be honored. And also, interestingly and concerningly, there is some reporting that's happening that some of the pulse coming from nursing homes may not be truly reflective of patient wishes, particularly for patients who are sort of at risk, disenfranchised / not able to communicate themselves. So if you get a form, the most important thing is to put it in the paper chart at the bedside, have a copy, go to, like, have the resident or attending review it, so that we can, one, vet it if it's looking suspicious, and two, get it scanned into the chart and reflecting the true code status of the patient. Every time those papers come in, we should be having a conversation anyway with patients and families to confirm or refute the status, given that there's clearly been a clinical change with their admission. Okay. Cool. Thank you, guys.